Welcome to Raaonline. So today we are going to see one of the very interesting trials, that is the Destiny 2 trial. Okay. So this is hemicraniectomy in older patients with extensive middle cerebral artery stroke. Okay. So this was in 2014, which came out in NEJM journal. So the clinical question is, in older patients with malignant middle cerebral artery infarction, does early hemicraniectomy compared with the standard care improve survival without severe disability or not? Okay, so this is a clinical question which is going to be answered in this trial. Point number one, you have many other trials like Rescue ICP trial, which speaks about traumatic brain injury, increased ICP, whether to go ahead with the hemicraniectomy or with the medical management. There are few other trials also which tells you about the hemicraniectomy in generally in patients above 18 years of age, right? But does really hemicraniectomy help patients who are older than 60 years in the elderly age group? Does the same results reflect in the elderly age group also, is the question which needs to be answered in this particular trial. Okay, so in elderly, right? So let's go into the study. So the study design is a randomized controlled trial, and the randomization is done via the online tool www.randomizer.at. Okay, and it is definitely non-blinded because a patient who has undergone a hemicraniectomy cannot be blinded, right, from the investigators or from the physician and the staff nurse, right? And the analysis is by intention to treat. To start with, they have started with intention to treat analysis for the primary outcome, and for sensitivity they have also conducted per protocol analysis. In our previous trial designs, we have explained what is intention to treat, and we have explained what is per protocol sensitivity also. Just for the benefit, I am just telling you again. For example, you have two groups, group A and group B, and people in group A are destined to get an injection called as injection A. Okay, injection A, and people in group B, injection B. Okay, there are 400 patients in group A and 400 patients in group B to start with. Okay, so eventually during the course of the study, 100 people walked off because the test dose was positive, so they did not get the injection, and 100 people eventually got injection B because the family decided that the patient needs to get injection B rather than A. Okay, so this is called as a crossover. So ultimately only 200 patients got injection A, and totally 500 patients got injection B, that is 400 plus 100, right? So if you compare this 400 versus 400, this is called as intention to treat. Okay, we are comparing team A with team B, the same as that how you started, irrespective of what happened to them in the due course. That is called as intention to treat analysis. The benefit is the randomization is still maintained. The comparative scale, that is 400 versus 400 sort of comparative scale, is still maintained, and this is what you see in your real-time practice also. If you offer a treatment to 10 different families, not that everyone will accept, right? 8 will accept and 2 may not. So this will let you know about the real-time practice. What is per protocol analysis? You are going to analyze patients at the end of the study. Literally, as per protocol, have they been up to the study is what you are going to compare. For example, out of 400, only 200 got injection A, right? So you will take this 200 versus out of 400, how many got injection B? All the 400. So 200 versus 400, this is called as per protocol analysis. As per protocol, what happened to them? As per protocol, did they get injections, and what was the analysis? So what is the benefit of doing a per protocol analysis? You can be very specific that this injection costed this to this particular number of patients, right? So this is called as a per protocol analysis. So here we have done the intention to treat analysis also of the primary outcome, and for sensitivity analysis, they have used per protocol analysis also. And sample size was calculated with a success rate of 8.6 and 90% power and 5% false positivity, and the sample size calculated was 160. Remember, the sample size is very important. The sample size is 160. Okay, the sample size is 160. Okay, and it is designed to stop recruitment as soon as harm, futility, or a major efficacy was shown. Understand that this is very important. When you are starting a study, you should be aware that there is something called as an interim analysis. What is an interim analysis? For example, your study says, for example, your study says you're going to recruit around 1,000 patients, okay, 1,000 patients over a period of 1 year, right? At the end of 6 months, you have recruited somewhere around 500 patients, okay. So, if your treatment has caused significant death or significant morbidity or significant negative predictive issues in that particular population, then it is time to stop the trial at that point itself rather than continuing it for really 1 year, continuing it for 100% of patients. This is called as an interim analysis. You are going to analyze the study somewhere in the mid or between, and you're going to analyze it's going to do more harm or it's going to be more beneficial also. Even if it's going to be showing more benefits, then also you have to stop the study, because ideally you are stopping that particular treatment from the control group, right? So you need to do an interim analysis. Will you do an interim analysis for every study? Answer is no. If your study population itself is very limited, then there is no point in doing an interim analysis in between, number one. Number two, the effect, the outcome which you're going to measure, if it's going to be very minimal, then there is no point in doing an interim analysis or stopping the study, right? But if your analysis, if your outcome is going to be like a mortality or a limb injury or a life-saving issues, then this kind of major outcomes is going to be your goal. Then you need an interim analysis to test whether you are harming the patient by continuing the study. In that case, you need to stop the study in between. That's called as an interim analysis. So this study was designed to stop the recruitment if any harm, futility, efficiency was shown in between. Okay. So remember, the sample size is 160.